Welcome to PEM Chatt. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. Well, I am very excited to be here today doing PEM Chatt with Tamarrah Davis. Welcome.
Thank you so much.
We're going to talk about puffy eyes.
I like it.
All right. Awesome. Tell me who you are and what you do.
So I'm Tamarrah Davis. I'm a physician. I work in pediatric emergency medicine here in Chattanooga at Erlanger Children's Hospital.
Awesome. Thank you for joining me today.
Thank you for having me.
A little arm twisting to get you here.
Very much so. I wanted to say one of us is excited, but we won't go there.
Well, I'm glad you're here, my coworker and my friend. So we are going to talk about puffy eyes today. This is something that I really wanted to talk about because in my prior life, working in the community ER before children's, this was something I really didn't see very much. And it was absolutely something I feel like I see over and over and over again in the children's setting. And it was certainly something I wasn't excited to see because I wasn't comfortable managing it. And I think everybody gets a little nervous with eyeballs because we know how important it is to make sure we do the right thing and make sure that we don't have any problems that are going to affect the kid long term. So it was something that I was hoping we could make everybody a little bit more comfortable with. So
that's good.
All right. So we're going to cover periorbital cellulitis, orbital cellulitis. Why don't we start with you giving me the basics? Like, what are these things? What do these words mean?
Sure. So I think, we talked overall, there are multiple causes of swelling around the eye, but the big infectious causes that we think about, the terminology varies a little bit, but for me personally, I tend to refer to these as preceptal cellulitis, meaning infection or inflammation of the skin surrounding the eye, and then orbital cellulitis, which has to do more with the contents of the orbit, like the extraocular muscles and the fat that surrounds the eye. And these kind of present differently and they have different complications. And so I think kind of establishing up front the terminology that we're going to use for this talk will help us out a little bit.
Yeah. So we'll start with preceptal.
Sure. Okay. Sounds good. So with preceptal cellulitis, we can kind of see these causing some swelling, redness, and pain around the eye. Again, you can have eye pain with this, but typically not necessarily pain with eye movement. And that's going to be something that's very important to distinguish. But this can arise from something as simple as a local trauma, like a scratch or a bug bite or something like that. You can get this coming from some sort of infection in the area, such as a sinus infection. But again, it really has more to do with an infection or inflammation of the skin and not the contents of the orbit.
And we typically see this in what age group?
So children in general, I will say, and less likely to be in adults overall.
Okay. And I was reading this morning, 3-4 is usually kind of like the peak incidence for this.
Well, you taught me something.
Awesome. I think that's a rare day. All right. So, and it typically is one eye, both eyes?
So it's usually unilateral.
Okay. What about like redness, bruising, if we see anything like that?
So redness around the eye, yes, definitely can be the case, but usually you're not going to have as much of like redness of the actual eyeball. This one is not. It is not that it won't have conjunctival involvement. It's just less likely to have something like what looks like a conjunctivitis.
Okay. And we talked a little bit about what causes it. Our usual bacterias we're talking about.
So skin stuff for this one. So definitely think about things like H flu, especially non-typable H flu in the setting of now that we have vaccines, but also with something like an insect bite or something like that. When we think about bugs that can cause that, you always have to remember staph and strep as far as them living on the skin as well.
All right. What about examining these kids? I know it's really hard when you have little bitty kids, to look at their eyeball. You have to pry it open and they fight you. Any like specific tricks on how we can get a better exam?
Sure. So it pretty much is whatever you can do to make it happen. I think the quote that I use is stand on your head, but whatever you can use to distract the child and move it so that, the child can look at something that they're interested in, whether it's a toy, whether it's the light, whether it's something on YouTube, basically something that you're moving in to get basically all full range of motion, I guess, of the eyeball.
Yeah.
So.
Yeah, Shelly said put Bluey on mom's phone and
absolutely
move it around the room. That was a cool trick that I didn't know before I worked at Children's.
Child Life can sometimes help with this. They have like the nice light up toys and stuff like that. And so sometimes stealing the stuff from them can be nice as well. So
maybe crackers. Okay, so what do you typically order for a kid that you suspect has preceptal cellulitis?
So honestly, you don't have to order anything for these kids, right? I mean, can you order labs? Absolutely. Is it going to make a big difference in how we manage these kids? Probably not. I mean, can you get a CBC? Yes. Maybe it'll show leukocytosis. Maybe it won't. Can you do inflammatory markers? Absolutely. But are these things going to make or break your diagnosis? Not necessarily. I think the big thing for these kids is you have to determine whether or not you're going to image them, because that's going to be where the money is for these children. Like, is this a child where you feel like clinically I can say, this kid has preceptal cellulitis and I can treat it and see what happens? Or do you have to get the imaging study?
Okay. What am I going to see that's going to worry me? That's going to say, I'm not so sure. Is this just preceptal or is this maybe orbital? And I need to be worried and maybe get some imaging.
Sure. So I think the younger the child is, especially less than 1 when they present with this, then you need to get imaging. I think if the child's eye is so swollen that you can't range their eye, like you can't even get it open enough to even see the eye moving, you probably need to get imaging. And I think when we think about special cases like kids who have already been treated and are on antibiotics and are not getting better, or they are not well appearing, or even that their degree of pain doesn't match what you see on exam, you probably need to get the imaging.
Sure. All right, so we decide it's preceptal. We are comfortable doing nothing, no imaging, no labs. What are we going to do to treat this patient?
So, typically for me, first line, if they don't have allergies, I'll choose Augmentin for these kiddos to be treated. But, in the setting of allergies and stuff like that, you can do a cephalosporin, something like Ceftonir. You definitely can try. But if there's any component of like local trauma to the area, you do need to make sure that you choose something that's got good staff coverage. So you may have to double cover with something like Bactrim plus whatever you were going to do before, like Bactrim plus Augmentin or something like that.
Okay. And outcomes, you put them on antibiotics. These kids get better fast, a week. What do we expect them to look like?
So I think kind of before we talk a little bit about outcomes, we need to talk about the importance of follow-up, because there definitely can be progression of this illness. And so these kids really need to be seen in like 24 to 48 hours. But typically, if it's just an uncomplicated preceptal cellulitis, you're going to see them improving in 5 to 7 days and with, near resolution or complete resolution of their symptoms. But again, they need to be seen to ensure that things are moving in the right direction.
Any special things to think about that would sway you to admit a kid that you suspect is preceptal, but maybe you can't tell?
Sure.
Well, how would you decide, maybe I need to put this kid in, do IV, as opposed to sending them home?
Mm-hmm. So I think if you can ensure follow-up for them, like if it's a holiday, if it's Friday, if there are other barriers for this child, as far as making sure that they don't get worse, that's going to be important. And, especially if you're talking to a family and maybe they're hesitant to get the imaging study to do a CT scan for whatever reason, but you do want to ensure that they're getting better. So I would just say mostly for close monitoring for these kiddos, or if there's some other comorbidity for them that makes them a little bit more difficult to manage.
If somebody was say from out of town, they're a few days from home, you weren't sure they could get good follow-up, but mom and dad seem responsible, you could maybe give them good precautions and say, if they're not better in 24, 48 hours, come back to the ER. Would you be okay with that?
I think for that kid, I probably would talk to the family about erring on the side if I had any question about going ahead and imaging them if we hadn't already, so that I would feel better about sending them home if there were ever any question. But I do think that the reliability of the family to know when to bring them back is very important in all of this, be it their understanding of what's going on, be it that we are speaking the same language, be it that whether or not they have the resources to be able to do it, transportation, things like that. I think all of those things play a role.
Sure. Okay, so let's move on to orbital cellulitis,
Sure.
and this is certainly the don't miss diagnosis
Absolutely.
here. So what does this typically present like? What am I looking at when I see the kid?
So typically these are going to be the kids who have pain with eye movement, but also can have limitation of range of motion of their eyes, or this ophthalmoplegia. I mean, some of them will actually have proptosis, like where their eye is kind of bugging out at you, for lack of a better way to put it. But, this is where it comes into effect, where you're trying to get that good eye exam to try to get them to move their eye in all planes, because you definitely can get, palsies that are representative of an infection in the deeper parts of the orbit.
Are they going to look sick?
Sometimes. I mean, they typically have fever and don't feel well, but I've seen also early that maybe they don't, but they truly have a limitation in range of motion of their eye. So not every child will look sick.
Sure. So I read on this, the typical incidence is 7-8 years old. Obviously children we're talking about, but this is kind of the peak of incidence. 98% of this comes from sinusitis.
True that.
How do you feel about that, given we kind of feel like a lot of kids don't get sinusitis?
That is a very hard one, right? Because I do feel like it's not that I don't feel that kids don't get sinusitis. I think that there is a lot of viral sinusitis, and that we may overtreat what is bacterial sinusitis. But I think if you really look at the numbers and the incidence of how many of these kids truly get an orbital cellulitis, it's kind of one of those things where if you do an evaluation of the risk and the benefits, is it truly worth it to treat every kid with green snot with antibiotics? I don't know the answer to that.
Because they might get orbital cellulitis.
Exactly.
Yeah.
But that probably is another question for another podcast.
Yeah.
So.
And I didn't look up the answer, so we won't go there.
Absolutely.
But I did read it most commonly comes from the ethmoid because of the proximity in the area.
And the bone, the bone there is so thin that you can, things can easily erode in that area. So.
Yeah. Seed from that area. Okay. So we talked a little bit about that presentation, kind of what to look for. It doesn't always have to have fever. Kind of the same, we think about the same bacterias as the general cause for this, but also opens it up to possible anaerobes if there's intracranial extension. I also read about PEM Chatt here, S. pneumoniae. What are your thoughts
fungus?
on? Yeah.
There's lots of possibilities, right? So, yes.
So potentially broader coverage depending on what the kid looks like.
And especially because of the proximity to the central nervous system, that's the other reason for the broader coverage, especially if you truly have a kid that looks sick, because which maybe we'll get to later, but talking about the potential bad things that can happen arising from an orbital cellulitis, like it can seed into the central nervous system. So.
Have you ever seen a kid present with CNS issues with this diagnosis?
I have not, but that's not to say that it doesn't exist. And I feel like if it was missed, it definitely could be something that could easily happen.
Yeah, I haven't either, but definitely on the list. So management for these kids obviously looks different. So how are we managing these kids?
So these are the kids that truly need to be imaged so that we can look at the extent of involvement, because, again, like I kind of alluded to a little bit earlier, you definitely have to worry about extension into the central nervous system. So thinking about something like a sinus thrombosis or something like that, you need to kind of, make sure that there's nothing else going on other than just like an orbital cellulitis. Mm-hmm. But again, first line a lot of times for a lot of these would be, we talked about preceptal cellulitis and using something like Augmentin or maybe even Unison for these kids, but Unison doesn't penetrate the CNS as well. And so typically for orbital cellulitis, you tend to go ahead and do broad spectrum coverage with vancomycin and Rocephin to cover them broadly until either they improve or you can prove that there's not something else going on or isolate something, which is also pretty rare. So
do we consult ENT on these kids? Do we need to if they don't have an abscess that needs to be drained?
I think that is probably a systems question and not necessarily a right thing to do question, right? And so Are there certain places where I think that ENT consult might be necessary? Yes. Are there certain origins of this illness that might make me more likely to consult ENT? Yes, right? So say this is rising from the inner ear, or say this is like some sort of like infected mucocele. Like, so if you can find a reason for it, then maybe if there's something drainable or something like that, yes. Emergently, probably we're not going to be doing it, right? But it may be something that, you know, when you're admitting them, the inpatient team may decide to do. But I think from an emergency standpoint, especially for us, that ENT consult emergently is not going to be something that we have to do.
Yeah, on a stable patient, we would just the floor can do it.
Exactly.
Non-emergently. All right. Outside of management, let's see, outcomes for these patients.
So, I mean, I think if you treat them, they do well, right? But it's, you know, if you miss it, like, I mean, you know, you can get loss of vision, you can get sepsis and things like that. So I think, you know, monitoring them closely on antibiotics to ensure that they're improving, absolutely, their long-term outcomes are going to be good. But
and I read usually
don't miss
24, 48 hours, they look markedly better.
Absolutely.
And we're worried if they don't, getting new imaging, updating that stuff, looking for something worsening. All right, let's talk about things that might present and look like it, kind of mimics of what this is, and how we're going to tell the difference between those versus something like this.
Sure. So, I mean, you know, I definitely think, again, you know, we talk about overall just periorbital edema in general. So when you think about swelling, you definitely don't want to miss something like nephrotic syndrome. I mean, I think that's, you know, something where we all kind of think about it and are looking for other swelling and thinking about, oh, do we get a urine? Do we need to check kidney function? Things like that. Is there some reason for why this child might have nephrotic syndrome? Congestive heart failure is definitely a possibility as well. Again, thinking about just causes of edema in general, but oftentimes it's not going to be just isolated to the periorbital region. We see a lot of kids, especially in the summertime, with insect bites, and sometimes it's really hard for me to distinguish between, is this more of an allergic reaction or is this infectious? And a lot of times I will have the family to treat both at the same time. And so I will oftentimes like have them to start some sort of antihistamine in addition to the antibiotic when I can't tell the difference. So I'm like, if it comes from an inflammatory standpoint, we're doing something. If it's coming from an infectious standpoint, we're doing something, and hopefully it'll get better either way.
What would you put them on?
I mean, I probably would just start something like cetirizine. And then depending on the extent, I personally don't always do steroids. But if there is some sort of question, sometimes occasionally I will put them on steroids as well. But I'm not a person who does that one routinely. So, in addition, something like angioedema, we do see that. But again, typically it's not isolated like a lot of the stuff that we've been talking about before. We see sometimes allergic conjunctivitis. You'll see a kid that was playing outside and then all of a sudden they've got this boom swelling. But a lot of times that is not painful and it's more itchy. And so, you know, when you feel pretty strongly that there's no infectious reason for why they might have this going on, you can just treat again with like antihistamines and stuff like that. But again, just be sure that you're talking to the families about the importance of follow-up. You can definitely have some local trauma. Typically they'll give you a history to go along with that, and that makes sense. But you do still need to warn people, because that local trauma still can lead to some sort of infectious process and stuff like that. So if it's getting worse, or if it's been several days since the trauma, you do still need to consider the stuff that we were talking about a little bit earlier. And then things like you know, a sty or something like that can definitely be a cause or a possibility for this, and you can kind of treat those supportively. But again, good close follow-up for any of the stuff on this differential that you think about or that you find is going to be important. So,
all right, let's talk a little bit about scripting. Our job certainly can be tricky when we're dealing with parents and families and just kind of navigating that thing. I think that's something we develop over time. So talk to me about, you know, how do you talk to families about this? How do you discuss, you know, do we need imaging? Do we not?
Sure. So I usually try to be as general as possible and let people ask me questions. But a lot of times, if I have a child that's well appearing, that's got some eye swelling, and I'm fairly confident that this is a preceptal cellulitis, I will talk to them about worst case scenario, being that this is actually an orbital cellulitis. And we'll talk about like, how do you distinguish with imaging? But what is the risk of imaging? Well, it's exposing your child to radiation, and they actually look pretty good today. And so usually I will bill it as your child is going to need imaging if they don't get better, but let's try to treat them for what we think is going on. Let's save them this radiation. And, if they get better, great. And if not, you just come back and we'll step it up. We'll step it up the next time.
So what is close follow-up? I know you kind of mentioned this, but this is like one of the most important steps. So
Sure.
What does that look like? How do you ensure they're going to get there?
So, I usually will ask people basically if they have a primary care doctor, and I usually tell them within 48 hours I'd like for them to be seen. And a lot of times, fortunately for me, I deal with the same groups, and so I know like which groups are going to be like able to see them or open or whatever. And sometimes that'll make a difference, like we talked about before, and who gets admitted and who doesn't. And so like, certain pediatricians, have weekend hours, and you're like, oh, okay, well then you can do this. Sometimes I'll even call though and be like, hey, I saw your patient, and we're going to start them on some antibiotics because they look pretty good today, but we are hoping that you can see them whenever. And usually they're very accommodating. So,
yeah. All right. So pitfalls and pearls, any words of wisdom, thoughts on the topic, things that have helped you along the way?
I would say, if you're going to lose sleep at night about whether or not to image the kid, just image the kid, right? Because, I've been surprised before. Everybody doesn't read the textbook about what they're supposed to do. And if you can't get an exam on a kid because it's 3 a.m. and they're a year and a half old and they're asleep and angry and you can't tell what's going on, just get the picture so you can know one way or the other one, because you will definitely have kids who have some component of involvement of the orbit where they don't have a fever. So, there are definitely rules to follow, but again, everybody doesn't read the textbook. And so if there's a question, you just do what you need to do.
Yeah. All right. Anything else you want to add?
I don't think so. That's more than enough.
All right.
Can I say this is over now?
We did it! You did it! I hope you enjoyed today's episode of PEM Chat. Join us next time when I'll be joined by Dr. Jordan Fouch, and we're going to talk about the limping child and septic joint. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance. Thank you for joining me here at PEM Chat. I appreciate it. Always a pleasure.
Same.
Dr. Tamarrah Davis.
Thank you.